Yes, yes.
ايوه.
Can you make a slide show, please?
Yeah, I'm just trying. Is all right?
Yes, yes, excellent, excellent, sir.
Yes.
You can keep it, sir.
Keep it there. Yeah.
الجو عندكم اخباره ايه يا فندم؟ بدأ يبرد؟
استحمى دلوقتي.
هو على طول بارد.
على طول بارد، بس هو
بدأ يمطر دلوقتي.
واخبار الغاز ايه؟ ايه الاخبار الغاز؟ الدنيا عامله ايه؟
لا الدنيا كويسه يا دكتور محمد، مش زي ما الدنيا
زي ما بيبينوا يعني
بيتقال يعني. بالعكس ده البنزين رخص والله اليومين اللي فاتوا دول يعني.
طيب
الديزل رخص.
دي حاجه نادره
بس دكتور محمد يعني. طبعا يعني رياضي. دكتور محمد راجل رياضي بيروح بالسايكلينج بتاع المستشفى.
ما شاء الله ما شاء الله.
انا سمعت الكلام ده.
دي ما الفائده الوحيده في دبلن. اسمع يا ابراهيم، مجبرا اخاك لا بطل.
ما انا عارف مش هتعرف تركب العربيه اصلا.
لا احنا في الساحل النهارده عندنا ميتنج، فالجو رائع بصراحه.
ما شاء الله.
صح، حضرتك في بورتو مارينا. في بورتو مارينا محمد صح.
الجو رائع بصراحه.
جميل
ما شاء الله.
اتعشى بقى في استوديو مصر ولا اتعشى فين؟ في سماك؟
اتعشينا في بورتو مارينا نفسها. انا خدت العشاء بسرعه كده عشان نلحق.
طب تمام.
الله. لا الجو جميل بصراحه الحمد لله. الجو الخريف بيبقى جميل قوي يعني.
بس انا مبسوط قوي، الشغل في المستشفى الجديده ماشي بسم الله ما شاء الله.
الحمد لله الحمد لله. بس الكوست عالي قوي يا دكتور ابراهيم. 3.5 مليار جنيه.
ما هو الواحد بقى بيسمع الاسعار دي، الارقام دي دلوقتي ما بيتخضش بصراحه.
لا
مع
بقى ده
لان اسعار الماتيريالز كلها غليت حتى هنا يعني
جدا.
يعني انا يعني اشتريت بيت السنه اللي فاتت، السنه دي زايد 100,000 يورو يعني في خلال سنه، ودي ارقام يعني.
انا كنت حضرتك في اوكسفورد من 3 اسابيع وجيت باسعار في انجلترا غليت قوي.
اسعار غليت انجلترا.
اخر مره كنت قبل الكوفيد على طول كانت الاسعار العاديه يعني. لا الاسعار غليت قوي.
لا خالص.
لا الاسعار زادت جدا. اللي طبعا اللي ادق مننا في هذا الموضوع الستات طبعا، هم اللي بيبقوا عارفين الاسعار احسن مننا. مراتها تقول لي التوست زاد مش عارف 35% والحليب زاد 18%. انا طبعا ما اعرفش، انا بروح ادفع كده وخلاص.
احنا علينا ندفع
بالكارت.
احنا الميل
بكام ده؟ ادفع وامشي زي ما يكون.
ادفع وانت ساكت. نو كومنت.
حتى اسعار تذاكر الطيران
طبعا.
كنت في لشبونه الاسبوع ده يعني. اولا المطارات في اوروبا اليومين دول بقت مأساة يعني.
ده المانيا
ضربات وزحمه وكان في ضرب. موضوع صعب. كنت في لشبونه وانا جاي في الشركه اللي هي راين اير دي، طبعا انت عارف شركه ايرلنديه بس
راين اير دي صعبه قوي يا دكتور ابراهيم. دي صعبه قوي.
اتوبيس غربي
بالظبط.
وكان ولغوا كل الرحلات ازاي، وبقى ضرب وخناقات والبوليس. وطبعا بقى ايه تلغي.
بس لشبونه جميله.
لشبونه نايس سيتي كده مؤدبين.
بالظبط.
لشبونه حلوه.
انا رحت حضرتك
بعمل اللي هو الامتحان بتاع الفاينل بتاع.
ورحت منها حضرتك كاشكاي دي على الساحل عشان اشوف حاجه واحده بس، عشان اشوف موريش كاسل. هناك في موريش كاسل، قلعه عربيه من التاريخ القديم موجوده جنب كاشكاي. طلعت حوالي 5 كيلو مشي لحد ما وصلت للقلعه العربيه دي. انا هاوي ان انا اتتبع اثار
القلعه
الاندلس.
انا والله ما لحقتش اروحها. انت حضرتك رحت شفت انت رحت المركز الاسلامي في لشبونه صليت فيه؟
لا ما لحقتش.
حاجه جميله جدا يعني، حاجه حجم بسم الله ما شاء الله. كنت هناك في الجمعه صليت الجمعه هناك، زحمه رهيبه يعني حاجه ظريفه جدا يعني بصراحه.
لا انا لفيت حضرتك الاندلس، رحت قرطبه وغرناطه واشبيليه وملجا وطليطله ومضيق جبل طارق جبرالتار. رحت كل الاندلس بتتبع الهيستوري جزء.
بلاش اللفه دي يا باشا، لا يشكوا فيك انت عايز ترجعها ولا حاجه.
لا انا تتبعت كل الهيستوري هناك، رحت قصر الحمراء، يعني الحمراء، يعني تتبعت التاريخ الاندلسي
جميله
كله. جميله
وفي حاجات يعني ظريفه جدا. تلاقي اسماء الشوارع، كنت ماشي
شوارع
في شارع
عربيه
اسمه لو اومير. لو اومير يعني عمير. وبعدين رحت احلى حاجه، رحت اول مره، انا فاكر اول مره رحت مدريد، دخلت في ماكدونالدز بشتري فيليه وبتاع سمك وبتاع، فبقول له عايز بوتيتوز، فالبنت مش فاهمه، قلت لها دي اسمها ايه؟ قالت لي بطاطس، قلت لها بطاطس، قلت لها هاتي لي بطاطس بقى.
انت عارف
هو في
حضرتك
البرتغال
مدريد
اسمها
اصلا اسم عربي.
بطاطش.
مدريد اسم عربي،
مدريد اسم عربي،
هي اسمها مجريد، مجرى الماء.
ولشبونه اسم عربي.
وفي بلد الوليد.
لشبونه اسم عربي. يعني حاجه سبحان الله يعني. انت حضرتك شفت المعبد بتاعنا اللي في مدريد، معبد داوود؟
لا،
في معبد مصري فرعوني في مدريد عمره 2500 سنه.
سمعت
موجود في
عنه،
قلب
سمعت
مدريد.
عنه بس ما شفتوش.
انا شفت، جميل، هو صغير مش كبير بس يعني لذيذ يعني، ظريف جدا، جميل جدا.
لا وده
رحت
ده سارقينه ولا عاملين فيه ايه ده يا
حوالي 7
ابراهيم؟
8 سنين.
زي
لا
المسلات
والله
كده، في حاجات هدايا.
لا يا باشا، ده واخد، ده رايح هديه يعني، ده ايام
هديه.
نقل فيله وايام، ده هديه. ده احنا بنهدي بمعابد، ده اقل حاجه عندنا ناس
ومسلات.
كتير من ده كتير.
انا
احنا
رحت
عندنا كتير
جميع
يعني.
المسلات المصريه اللي في العالم.
انا شوف حضرتك رحت اسطنبول اكيد يا دكتور محمد؟
رحت المسله اللي في اسطنبول، واللي في روما.
شفتها في
واللي
واللي
في
في
اسطنبول،
روما،
واللي في روما، واللي في باريس، واللي في لندن،
وباريس،
واللي في
لندن،
واشنطن.
وفي واحده اللي في واشنطن اللي عند الوايت هاوس دي
رحتها عند
ولا
الكابيتال هيل كده.
يعني. ده احنا اقل واجب عندنا مسله، ده حاجه بسيطه
دي
يعني،
دي الهديه
مسله كده
البسيطه.
عادي جدا. دي زي ما بتجيب لواحد كده ميداليه مفاتيح وانت راجع من
بس
السفر
ده
عادي
يدل
جدا.
على ان التاريخ المصري يا دكتور ابراهيم منتشر في العالم كله.
ما هو طبعا احنا اذا كان اقول لحضرتك على حاجه، مش عارف انا قلت لحضرتك ولا لا، في قبر اميره فرعونيه في ايرلندا.
ده راح قبر تابوت يعني.
موجود في ايرلندا في كيري.
اه
لا، قبر،
وتورينو،
مقبره
متحف تورينو
فرعونيه
في ايطاليا،
لاميره اسمها
ده اكبر
سكوتيا.
متحف للمصريات في العالم.
يعني لا ده في اميره كانت عايشه في ايرلندا، متجوزه ملك ايرلندي من حوالي 2700 سنه. احنا واصلين ايرلندا يعني، انا هطالب بالورث يعني قريب.
طبعا من حقك يا بيه، على الاقل تاخد شقه هديه يعني.
اي حاجه جنب
جنس هديه
اقول لهم يا جماعه
بدل
انا
ما انت
اولى بلحم
بتشتري بيت.
جدتي دي ولا مش جدتي؟ جدتي.
دي يا ابراهيم انت عرفتها من فين؟ ده انا اول مره اسمع بيها دي.
ايه؟
دي عرفتها من فين الفرعونيه في
لا،
كيري؟
في بص، اكتب كده اللي هي سكوتيا. عيب عليك، ده الدم بيحن برضو انت. ازاي؟ في اسمها سكوتيا كوين سكوتيا، موجود في
سبحان الله.
ترالي في كيري. هبعت لك اللينك بتاعها، هبعت لك عشان
ابعد
تزورها
يا باشا.
تقرا الفاتحه.
احنا
اهلا يا
قدامنا
دكتور
بالظبط
كريم.
5 minutes يا فندم عشان الاودينس يتجمعوا ان شاء الله.
اهلا دكتور ابراهيم، اهلا وسهلا، منورنا.
كريم
منور
حبيبي.
دكتور كريم.
اهلا بحضرتك،
ازي
اهلا وسهلا
حضرتك؟
دكتور. الله يبارك في
هو
حضرتك دكتور ابراهيم، اهلا
قاعد
وسهلا
ساكت
دكتور محمد.
بيسجل، انا قلقت والله يا باشا.
لا يا باشا والله مستمتعين بس
كريم
بالحوار.
مدرس عندنا دلوقتي، وهو سبيشالايزد في الشولدر ارثروبلاستي يا فندم.
ما شاء الله ما
طب
شاء الله.
تمام.
يا رب يبارك في حضرتك.
بقى مع الحاج
كريم
محمد
رحب
بقى
بالدكتور
يظبطنا ان
محمد
شاء
بيه
الله.
جعفر.
دكتور محمد منورنا يا دكتور محمد، وان شاء الله يكون يوم جميل بوجود حضرتك ودكتور ابراهيم واستاذنا دكتور محمد ان شاء الله، ومنتظرين ان شاء الله سهره جميله
شرف
ان
لينا
شاء الله
دكتور
نستفاد بيها
كريم،
كلنا، وشرف لنا
ان
وجود
شاء
حضرتك
الله
معنا ان
ان
شاء
شاء
الله.
الله نستفيد كلنا.
ان شاء الله تعالى ان شاء الله.
اوعى تكون يا كريم كنت عامل الدكتوراه على الريفيرس شولدر ارثروبلاستي ولا حاجه؟
لا والله، هو دكتور محمد على فكره يعني دكتور محمد تشرف طبعا، هو مشرفي الرئيسي، وهو دكتور محمد احنا ما كناش بصراحه، كنا بعاد شويه عن
لا
الشولدر، فهو دكتور محمد اللي اقحمنا في الايرا دي يعني بصراحه، وصمم ان احنا نشتغل شولدر الحمد لله.
هي حاجه كويسه،
اشتغلنا في
حاجه
يعني
كويسه
رسالتي
جدا.
كانت عن الهيمي شولدر في الفراكشر كيسز، كومبلكس برايمري proximal humerus fractures, fracture dislocations, complex fractures. فالحمد لله يعني حاليا احنا بنشتغل شغل ريجولار في الاسم، ولسه ريفرسل بصراحه يعني ان شاء الله يعني جبنا دخلنا المفصل، بس لسه يعني لسه ان شاء الله الفتره الجايه نمشي فيها اكتر ان شاء
الله. I think ان الريكوردنج بدأ، فاحنا كده اونلاين يعني. محمد بقى اشهد
نبدا يا فندم.
اتفضل.
بسم الله الرحمن الرحيم.
اتفضل حضرتك.
هنبتدي ويبينار النهارده مع ضيف عزيز غالي، بروفيسور محمد جعفر from سان جيمس هوسبيتال. طبعا يعني مرحبا به يعني ضيفا عزيزا في بيته الاول في كليه طب بنها يا فندم. طبعا انا يسعدني ان انا ارحب باخي الحبيب العزيز دكتور ابراهيم قمر، consultant of orthopedic in Ireland, Sligo University Hospital in Ireland. دكتور ابراهيم طبعا له ايادي بيضاء كتيره على الكورس التدريسي منذ سنتين مضوا، فانا طبعا مرحبا بك دكتور ابراهيم، يعني ده بيتك، انا مش هرحب بيك في بيتك يا فندم. برضه معايا ابني دكتور كريم خاطر. دكتور كريم مدرس في قسم جراحه العظام في طب بنها، سبيشالايزد في الشولدر ارثروبلاست. نشرف بحضرتك دكتور محمد بيه، ضيف عزيز عندنا يا فندم.
شكرا دكتور محمد.
اتفضل يا فندم.
طيب بسم الله الرحمن الرحيم. First of all, السلام عليكم. Like it's really I'm very delighted يعني ويسعدني ويشرفني جدا إني أكون معاكم هنا يعني. And many thanks for Ibrahim يعني he's the one arranging the meeting. It's really a pleasure to join you guys. I hope we'll get the benefit all of us. So Mohamed Gaafar, my name, I'm an orthopedic consultant at St. James's Hospital in Dublin. It's one of the main hospitals in Dublin. It's the biggest hospital actually in Dublin, over 1,000 beds, more or less same like a Demirdash hospital in Egypt, you know. So I'm specialized in the shoulder and elbow. Yeah, if you don't mind, like I would talk in English just to make it easy. I will speak in Arabic in between. If anyone had a question, can raise the hand, or you can write it down, and then we'll answer it at the end of the presentations. So the idea to start with the shoulder arthroplasty is a big thing to start to talk about it. So for me, that's all like a lectures. It's just as introductions for the shoulder arthroplasty. I think if ربنا لو مد في العمر إن شاء الله we'll try to do another topics in particular pathology, so we go for more details. So let's start it about the history. They said everything started with the history. So what we reach it now in terms of the shoulder replacement, it's really great work and hard work done by a lot of people before us. And we should really be appreciating that. And the first shoulder replacement actually was done in 1893 by a French surgeon, Guillaume Ban. And he put it because he was planning to amputate one of the soldier, the French soldier. He got a tuberculosis and he was planning to amputate his arm. And the guy refused. He was 23 and he refused to get amputated. So he decided, okay, I try to do something for this guy. And then he put the first shoulder replacement. And in fact, that was the first joint replacement put ever in anybody. Like it was before the hip replacement or even knee replacement, which was done like almost around 1950, and the knee replacement 1973. So that was the first things. Eventually, the shoulder need to be removed after 2 years because the guy ended up with a fistula around the elbow. And this picture you see it on the left side, that's the true picture for it. The guy after he passed away, they put it and they put that in the museum for him. So that's how they started. And no one after that tried anything till maybe 1950 when a German surgeon, Groger, tried to implant the first metal implant to deal with the A vein of the proximal humerus, and was made from vitellinium. And although that was the first one, but I don't know why it didn't get the row until Charles Neer, the pioneer of the shoulder arthroplasty in 1951, and 1 year after that, he decided to put his first metal implant, which was a monoblock with the fixed angles, cylindrical, as you can see it on the picture here. He tried to replicate the proximal humerus to deal with the patient with doing bad, with not quite happy with the outcome of the proximal humerus fractures. So he is the one firstly put the first generation implant monoblock. However, he wasn't quite happy because although the pain was much better, but the function was quite limited, particularly for a young patient. So maybe he keep working for about 20 years before he tried to get the second, the near two, which he make it from same monoblock, but at this try to put the longer stems. And he was thinking, if I put a longer stem, I may try to reduce the torque around the humerus, and that may give me a better functions. At the same time, he invited the polyethylene keels for the glenoid base, and that was almost like his second generations for his shoulder replacements. And from 1970 till 1980, his non-constrained shoulder replacement was the main shoulder implant for all shoulder pathology, regardless what the underlying pathology. Is it arthritis? Is it post-traumatic? Is it the AVN? Whatever they've been dealing with the near to shoulder replacement. And although he started to get a good outcome, he published his result, was reasonable and everything, but he noticed that the outcome was very poor in the patient with the cuff tendon tear or injury. And he tried to figure out anything to do it. So how I can overcome this. And he came with what we call a Mark I, and that a constraint implant in order to try to make it unstable, to try to overcome the dysfunction cuff. Unfortunately, he used to put this implant on the right side, which like a base ball and socket in the reverse way, but at the same time try to repair rotator cuff. But he put the head quite big to improve the range of motion, and he found himself he wasn't able to repair the rotator cuff. Then he came with the Mark II, where he make a smaller ball, but again he find the range of motion was quite limited. After that, he get the Mark III, where he tried to make some axial rotation around the stem to decrease the load on the ball part of his joint. He published a series of cases with a poor outcome. So he noticed that at the end of his paper, he put it very clear that the shoulder replacement in the patient with the cuff pathology had a poor outcome, and he wasn't able to figure it out from there. Meanwhile, there was a lot of work being done around all the world in UK, in Stanmore's, the Pickles prosthesis, the Stanmore prosthesis, tried to overcome the dysfunction cuff in a patient needed a shoulder replacement. At this stage, the shoulder surgeon divided in two groups. A group that tried to work with a constraint implant, try to overcome the pathology of the rotator cuff and how they overcome that. Other group try to improve the function of a constraint implant to get what we call it at this stage, the anatomical shoulder replacement. So from this stage, which around 1980, two groups of surgeons been working in two directions. So starting with the anatomical part, the second generation customized here, people realized that the proximal humerus had a different anatomy. The head is different, vary from one person to other. The lengths of the inclinations, the reversion, everything is different. So try to get some modularity of the stems. Particularly, they noticed that people around that time, they start using it more around the hip. And so they try to copy them in order to get that. And that way we get the second generation shoulder replacement. However, still the outcome in terms of the function was limited. Even with the attack of the range of motion wasn't great. So till 1980, Pascal Puello and Gil Walsh tried to study the anatomy of the proximal humerus. And they noticed that it's quite complex more than how it looked. In fact, they found that there is a lot of variation of inclination, of retrovergence. The thickness of the head, although it could match the diameter, but it varied from one to others. So the shape of the proximal, the head itself, it is spherical, it's not completely round. The shaft is cylindrical. The offset is a posterior and a medial, so it's quite complex than just a simple ball things. So at that stage, they decided and came with the third generations, where they have a lot of modularity of the stems. The ball itself, they get the offset posteriorly and posteriorly and distally in order to try to copy the normal anatomy. The progression keep working, and we reached what we have at the moment, which is the 4 generations, where they increased in more offset, they gave more offset, they gave more option of inclination, a lot of options of version, and that's what we have it right now. On the other hand, the people that working on the constraint implant, they were still struggling to figure out an implant that could do the job for them. And that didn't happen till, just to show this picture, that's what we have in the UK, in the Europe now. So that's all the kind of anatomical shoulder replacement we have it in Europe. A different company, a lot of options, more or less they do the same job. Different biomechanical in terms of fixation, metaphysical fixation, keel versus screw, the press fits, it's a different thing. But the basic anatomy is more or less the same. So in 1985, the French surgeon Paul Gramont came with a completely new concept, was absolutely something completely new to try to overcome the rotator cuff pathology. And he tried and he figured out that in order this shoulder replacement work, first of all, it needs to be stable. All the previous implant, they used to fail around the glenoid because it wasn't stable enough, and there was a great force around it. The second thing, he figured out that the weight bearing, it should be the convex part, and the weight bearing of the shoulder is usually the glenoid. So that means he needs to make the glenoid convex, and that's where he came with the idea about the reverse. And then the support part, it should be the concave, which is the humerus. The other thing he found that the center of rotation, it should be spherical, and it should be within the glenoid neck. And the last and the most important thing, the center of rotation should be medialized and distalized. And the idea behind this concept, he tried to overcome the function of the rotator cuff by using the deltoid, which is a great idea at that time. So he started and he was working very well, and he put his first implant, was absolutely doing very well for about 5 or 6 year time. He published his result, it was great, but still he found still the range of motion not as expected. So then he went and he got the second generations, which we have it till now, and they improve it to the third generation, but still they call the same implant by DQ and the Delta 3. And here he tried to medialize more the center of rotations by decreasing the size of the glenosphere from 2/3 to the half sphere. In addition, the base plate, he fixed it further by breastfed back, and he put another 2 screws, as you can see it in that pictures, and that in order to resist the shear force that happened around the glenoid to avoid glenoid losing. So that's after that he was quite happy in terms of the glenoid, and in 1994 he started working more on his proximal and the humerus component, try to get it more in terms of hydroxyapatite, in terms of first coating. He go through different stages before he reached the final implant that we have it till now. We use it in fact. So that was the concept going from if you take it there from 1985 going till 1998. Where is this guy? Not sure if anyone familiar about him. His name is Mark Frankel. For me, this guy is absolutely genius. And when I'm saying he's absolutely genius, because if you try to imagine someone like Gramont, he came with implant from nothing, from completely new idea to overcome a major problem that people for about 50 years wasn't able to overcome it. And he sorted it out, and his patient was doing fine, his implant was just doing fine, everyone happy, although there was some problem with his implant regarding the glenoid notching and some problem, but overall was fine. So this guy came with absolutely new concept. And his idea came by absolutely what he put in his ear. He always put and continuous research in new method allow me to reassure my patient that I always get in the best treatment available. Mark Frankel, he's a very senior shoulder consultant. He's working Florida Institute of the Shoulders. And this quote, he always put in the top of his clinic. And that's what he get it. He came with the new concept, absolutely from nothing, that no, this medialized center of rotation is not right 100%. In fact, if we lateralize the center of rotation, we should get a better functions because we're going to tension the deltoid more and we'll avoid the other complication that happen with the medialized center of rotation, which is particularly the scapular notchings. So he came with the lateralized implant. And this picture give you idea here, just to summarize what we have now in the market in terms of the reverse shoulder replacement, because it's quite confusing. So if you look to the first picture on the left side here, that more or less that's the Gramont styles, where we have a medialized glenoid and medial humerus. And you can see your offset here, the center of rotation exactly 0. And the humeral offset is the standard will be around 10 then. And if you can see this, it worked nice because it distalized and medialized. But the problem with that, you always end up with some degree of notching of the scapula around here. So the second implant here, that's exactly what Mark Frankel came with it. And he tried to lateralize the center of rotation from glenoid. So rather than he put it here, he increased to almost like 10 millimeter outside. That put more tension on the deltoid. And at the same time, to avoid the notching around the scapula here. A lot of people critique him until he published his paper after 10 years with excellent outcomes. So everyone was impressed. And then they said, okay, so why we don't leave this here, the glenoid in the same place, and then we try to lateralize from the humerus rather than we lateralize from the glenoid. And then they came what we call the onlay reverse shoulder replacement. So that if you see here the center of rotation, more or less it will be at the same spot or a little bit lateralized, but the most lateralized of the humeral offset is almost like over 20 millimeters. Then people go more and try to lateralize both of them, and that quite often still they didn't get a great result because they end up with overtension in the deltoid, and you end up with some fracture of the acromion because overtension of the deltoid. So this 4 picture give you idea about what do you have now in term of implant available in market. So the next question will be asking yourself, so which one I'm going to do it, and for which patient do I need to put? I'm going with a shoulder replacement. I'm going with the reverse. If I'm going with the reverse, which type of the reverse? I'm going with the hemi. So where I'm going from here? So, and my answer for that, in medicine, for me, there is something called a rule. We do have a guideline to help us to make a decisions for the patient, but all your decision from the simple fractures, you're going to fix it like a distal radius to the major complex surgery you do it in your life. It should depend on the 3 things, okay? First of all, it should be your patient factor. You have to look to the patients from pathology-wise, what kind of pathology he does have. Try to understand his pathology propers. Is it a proximal humerus fracture? Is it AVN? Does he have any glenoid erosions? The other thing, you have to look to the patients for himself in terms of age, in terms of function, in terms of requirement, in terms of ability to motivations enough to go for rehab. All these things, it makes you to make a decisions. So that we call it the patient factors. The other thing, you have to look to what we call a surgeon factor. Are you trained to do these things or no? You may know this patient, he may benefit, get very well from, say, reverse shoulder replacement, but you are not trained enough to do it. While you have a good experience to do a hemi, then this patient will do 100% good with the hemi rather than reverse. The third thing, which is the most important thing, particularly for us in the Middle East, is an implant thing. So sometimes we don't have the implant. We don't have the right implant. So you have to play your decision around these things as well. But as a guideline, those some guideline for the patient when you decide to go for a hemi. So if you find someone like over 60, had no significant comorbidity, he does have a primary arthritis, he does have like a type 1 glenoid, no previous surgery, no feature of instability, his cuff is intact and functioning, and he motivated enough to go, this guy generally, he should do well with the hemi or total shoulder replacement. And we come gradually down here, we find that a lot of patients with for a hemi, they start to decline using the hemi for the patients. Like the indication for hemi coming really very, very down. Very few patients now, you need to put a hemi for them here. I know that we've been using it a lot, particularly Middle East. When I was in Saudi Arabia, we used to put a lot of them. But now here, and we've seen the NGR data here, the hemi become very, very uncommon to be used here, unless for certain people. The other things, to go for anatomical replacement, more or less the same thing, but you do need a well-functioning rotator cuff. And when I said the functional rotator cuff is not an intact rotator cuff, there is a big difference, because you may get a patient had an MRI with intact rotator cuff, but he's stiff like a stone. So his cuff is not functioning. You know this guy, if you're going to put a shoulder, anatomical shoulder replacement, it will not work. It will fail. It will become unstable. He will be stiff. He cannot go through rehab. He put a lot of force around the glenoid, and you get a glenoid losing after a while. So make sure that patient had a functioning rotator cuff, no fat infiltration, not stiff, and it's not that old. All people do generally well with the reverse. The other thing, when I said all people, that's a bit different thing when you compare all people in the Middle East and here. So here, 80 years, still not all, is still looking to functioning well, is still looking to go do her gardening, take her dog outside. So it's completely different from us in the Middle East. So again, looking for a patient demand rather than really the biological age for him. So when you think about reverse shoulder replacement, those two are indication. For me, the reverse shoulder replacement at this stage, it could be for everybody, unless otherwise. So all patients usually go for reverse, they do well. Patient with a calf atrophy, they do well. Patient have previous instability, they have a posterior fixed posterior subluxations, you need to do reverse. They don't do generally well with anatomical. And the patient that has significant glenoid bone loss or erosion, particularly if this erosion eccentric, not eccentric. So if you have posterior erosions, and that's another topic we may go through it at some stage, that the type of the glenoid erosion, you have it, and the degree of the glenoid, and how can you overcome that bony defect. But in generally, the anatomical replacement, till recent time, it have a very limited option to deal with significant glenoid erosion. Nowadays, there is few implant and design come to overcome that, but to a certain degree. So in general, if you have someone with significant glenoid erosion, you'll be able to manage it well with a reverse shoulder replacement rather than anatomical, and they do generally well. So what the literature tell us? Okay, first of all, you have to know the shoulder is not like a knee or the hip. So we know that the hip guys, they know that, oh, if there's a bad hip arthritis, if you wait for it overall, the outcome is not the same as you do it earlier, because you end up with a protrusia, you end up with a degree of bone loss and a lot of things. That's not in the shoulder. So the shoulder is still the outcome. If you delay your surgery, the outcome more or less will be same. There is no big difference, even with anatomical shoulder replacement, which is a good thing for us. We are not working on our shoulders. The other thing, the shoulder replacement, the anatomical, can you do it for all patients? The study is still supporting that. And that's why I said it's a good outcome, even in the patient over 8 years of age. And the reason for that, I always said, look for the patients. It's 8 years is here, not like Middle East. They're quite active, this guy here. So if we carry this study in the Middle East, it will be completely disaster for us, trust me. So the other thing, the coffee study, that's one of the nice studies. That's all like a new study. You can see it just being presented in the Hamburg and last March. So if you have a partial thickness rotator cuff tear, we still be able to go with anatomical. So it's not an indicator for you to go for reverse shoulder placement if you have the partial thickness tear. The patient still will do well. You'll not get loosening of the glenoid, and you get a good function, at least in the medium term follow-up. We may need to look after that after 10 years to see how they're doing. So that's one of our paper here. We did it with our research group, and we published in Journal Shoulder Elbow just 2020. And we looked to a systemic review to see the return to sport after reverse shoulder replacement. And you'll be surprised to know that almost nearly 80% of them return to sport, and over 70% return more or less to the same level. When we are talking about the sport here, we're talking about a group average about 74 years. So we are not talking about weightlifter, we are not talking about rugby. So most of them, they are golfer or a swimmer or tennis player. So overall, they're quite fine to go back to the baseline, which they needed this guy here. Again, we look for a meta-analysis for the proximal humerus. That's again with our study groups, and we published that recently in the journal and the injury. Again, we find that reverse shoulder replacement considered to be the best option for proximal humerus fracture, to deal with the proximal humerus fractures with the least morbidity and the least surgical required of revisions rate. Doesn't mean anyone in your country or here, you're going to have a reverse shoulder replacement. That's not right. But for selected cases that they have a nasty proximal humerus fracture, they do well with a reverse shoulder replacement rather than other method of fixations. So the other things, and the last paper, I don't want to put a lot of paper here, but the last paper here, that's from Journal Shoulder Elbows. If you have an intact cuff with arthritis, would I be able to put a reverse shoulder replacement? And the answer is yes, you can go for that. And actually the short-term and mid-term follow-up is excellent so far. Again, as we said, in the reverse shoulder, we are almost reversed in the normal anatomy here. So we cannot say if it's someone with intact cuff, that's a definite answers unless we follow that for long term. So we don't have a long-term follow-up. We still need to see this guy, how we're going to do for 10 or 15 years. We have to bear in mind when we are talking about shoulder placement, we are talking about a variety of age group. This patient may be 35 years, had an AVN, and maybe someone 78 years. So that's a big variation group. So still we cannot treat them all the same. We need a long-term follow-up before making such decisions. Okay, so again, and that's a very common, and that's one of the paper, why we don't put a reverse shoulder arthroplasty for everyone, and they look for that. Almost there is a 13 study to see if you can put a reverse shoulder in anatomical shoulder replacement, and all of them, they have excellent scores and very low complication rate. But as I said, that is still, we consider like short to mid-term follow-up. We don't, still is not long-term follow-up. And you can see here, the main age of the patient was 68. So I don't think that's the right answer to say for someone with like 40 or 50 even. So we still, for me, that's not a definite answer yet. So the question now, how we are doing now, how things going now in Europe now. So we starting between UK and Ireland here, we starting the shoulder placement maybe around more than 15 years ago. And the National Joint Registry started to register all the shoulder replacement since the last 13 years. So we're just having a look. So this the table may be a bit busy, but this will give you an idea about the number of cases being done in 2021, last year. So there was a total over 6,000 shoulder replacement done through all the UK. So that's a national joint registry. If we look to this, all 68% of this shoulder replacement was reverse shoulder replacement. So we can see now we are going more toward the shoulder replacement. Only 25% was anatomical, and only 8% was a reverse. So that's a really drop. If you compare this slide with the next slide, which was 2013, 9 years ago, there was 4,000 shoulder replacement overall. 35% of them was only reverse. So almost the double of the percentage of cases we do it now, or all that's what going to reverse. Hemi at that time was 17%. Resurfacing was 15%, which is very minimal, and 5% was resurfacing of the arthroplasty of the joint. That could be one of them. Sometime using the biological fixation, that's another topic about it. But that's give you an idea where we've been and where we are now. So we are talking about hemi arthroplasty 8% in total, and here we're talking about hemi arthroplasty nearly 37%. So quite significant drop, and we are moving away from that because we have a better option of fixation now and stabilization now of glenoids. That's just a graph to show you the difference, and you can see most of the 2021s, they're all reverse. 70% of the NHS hospitals, apart from the private hospital, going with the reverse shoulder replacements. Compared with the 2013s, a different variety of options, most of it between hemi and anatomical shoulder replacement. Okay, so what this procedure done for it? So 51% of these cases was they had a osteoarthritis. So we are talking about 60%, more than 68% getting reverse shoulder replacement, and 50%. The most common cause of the shoulder replacement it was osteoarthritis followed by rotator cuff arthroplasty, in addition to the trauma for sure. So that's another give you details what the standard of guideline and that's important to have a joint registry, national joint registry, because that's your guideline. You do things here not based on your experience. You don't think because you do it because the guideline like that. So almost 90% of the people they use like a delta pictorial approach. So if you do that, you're on the safe side. Do you need to do tenotomy? Do you need to do craniodiasis? That all give you an idea here. Do you need to use a bone graft, not a bone graft, to give you an idea where we stand? That's in terms of the complication. So what complication it happened? And that's important as well when you counsel your patient. You talk to him pre-op. The guy here is quite specific in terms when it comes to consenting them. You may spend 30 minutes to try to explain the guy everything in details, every complication, and they start asking you about numbers, which is very confusing for you as a doctor to say what the number. So in general, intra-op complication for the shoulder replacement is about 2%. That's what the data show us so far. If you compare that 2013, that's almost like triple that number, is about 6 to 7%. Most of this complication related to humeral fracture and glenoid fracture, vascular injury, very minimal, like 3% out of 2%. So it's really very minimal things to happen for you, but it's a serious complication. That's why you need to consent your patient and talk about it for that. So what next? Where are you going from here? If there's any way for improving, could we get it better? Definitely yes. So far, if we're talking about the anatomical shoulder replacement, as we say, I think anatomical shoulder replacement, we may see some improvement in the future. I think in the 10, if we look to this data 5 years from now, it will find that anatomical shoulder replacement start to catch up, because now there is a lot of new design to try to overcome the glenoid bone loss. Because most of these patients, we find ourselves, we do them despite there's intact rotator cuff, but there's significant glenoid bone loss. So they start come with a base plate of men, polyethylene of men. They start to come with a hybrid fixations to overcome that. That kind of fixation that you can revise it in the future if you want. So they're improving from this point. In terms of the reverse, you can see we're moving from the longest stem to the shortest stem, try to rely more on metaphyseal, try to preserve the bone, the implant designing getting better. We start to get what we call hybrid fixations for the anatomical here. That's kind of the socket that you can change it later on if you need to put a reverse, which is a good option for someone who had a massive glenoid bone loss. So people start using the programming quite often. For us here, we have our system, we use what we call a match points. For most of the cases, even if you don't want a PSI, even if you don't want 3D model CT scan for you to come, but you just help you to make your orientation, where we're going to put your central screw for the humerus, your humerus cut, your version, if you have a bone loss, how much you're going to get a contact, it give you a good idea. So a lot of people moving towards that. Like the last National Joint Registry found out we use this for about 3%. I think next year that may be 15%, or 5 years maybe in all cases. We start using PSI quite often, so particularly for complex cases, you have the PSI, they get you the gig, and then easy peasy, everything goes very smoothly after that. More recently, we started using the mixed reality. I'm not sure if anyone had experience like that. I did have it, of course, I never tried before in a patient, but that's this picture actually for one of our colleagues here, Ms. Ruth Delaney. She's one of the consultants in the Dublin Shoulder Institute here, and she's the first one putting this mixed reality shoulder replacement. She does have that in the YouTube or at her website. You can have a look for it. It's very interesting. The idea is the same like a 3D modeling, but you have it in front of you. So you have your PCI jig and her right and her left picture here, but at the same time you have the model in front of you while you're putting your glasses, and you'll be able to check where is your jig going while you're doing a surgery. So that's make us getting better outcome, no doubt. You'll be able to overcome a lot of complication, a lot of bone loss, a lot of things you can avoid it, and definitely make your surgery easy, no doubt. So I will just end up with a few cases I did here, just to give an idea of what we can do with a shoulder replacement. So this patient here, 73 years old female, she's right-handed with the shoulder OA. As you can see here, she's a very keen golfer. So her MRI showed that she had a small partial supraspinatus tears. Her glenoid erosion was completely centric, so she doesn't have any eccentric loading. She doesn't have any decentralized of her humerus. So because she's 73, we still gave her the option of reverse, but she's quite keen to go back and play golf. So she didn't have a significant bone loss. So we go on and put a shoulder replacement for her, and that's the implant we use here. Eclipse from Arthrex, which had long-term follow-up. It's one of the first implant came in Europe here. It's been in the market for a long time. They have a longest standing outcome. So far she's doing fine. That's her picture in the 6 months, and she's being discharged from our service now. She's happy, delighted. Other case, that's a 93-year-old right-handed lady. She had a mechanical fall while she was fixing her gardens. So anterior dislocation, A&E guy, excited, roll up their sleeve, let us push it back, pull it, give it a good tractions, and that's what you end up. So then, we make it worse. Let's call the orthopedics. Okay, the orthopedics, I'm not free to see it, get the CT scan, and that's how your CT scan end up. So the lady's 93 years. She had that 3-part proximal humerus fracture with the head and still anterior dislocated. What you're going to do for her? So I'm not sure what the really answer really will be there in the Middle East, but like this guy here, this patient and those patient here, they don't accept, like you said, okay, I'm going to leave it like that. You are 93. I cannot put you through the risk of the surgery. They don't accept these things. They need that to be right. If I'm gonna leave for 20 days or 10 days or 1 day, I like my shoulder to be in the place. So the option here, which we try to reduce it, put it back, fix it. I don't think she's gonna make anything. You can see this lady, she had a very minimal subchondral bone around here. It doesn't give you any support. So we end up putting a hemi for her. And if you can look for this hemi, that's what we call a CTA hemi. So it's a cuff tendon arthroplasty hemi, which is the very large hemi, like a full. So even if, because she's 93, her rotator cuff, it will not be great. You're not, even if you get a good repair of her glenoid, she doesn't, of her GT, she doesn't have the good biology to heal. And I was able to manage a part of her GT. You can see the picture there. The part of the GT is still there. I was able to get it back in place, but I know it's not going to heal. And for long term, this GT will going to just come off. So even if this had happened, she'll be fine because that long, big head here, we're going to articulate with the chromium, she'll be okay. So she was fine. She discharged home and she's okay. She's doing fine. She's flying, actually. This lady, she's one of my best patients so far. So the other case is, so that's a very interesting case, actually. He's 68 years, very nice guy, right hand dominant. He failed post-epileptic seizure, first time epileptic seizure, and he came with the ANE. His background is cardiac arrhythmia. The guy that think the epilepsy because of cardiac arrhythmia, I don't know how. Anyhow, he ended up with these pictures. So for us, ABC orthopedics, epilepsy, electrical shock, posterior dislocation till prove otherwise. Unfortunately, the guy did get these two pictures for him. There's no axial view, and they were not able to think outside the box. Let's see things. So this guy completely missed, unfortunately, posterior dislocation. And even if you didn't get a proper axial view, even if you didn't notice that the patient had epilepsy, one thing in this X-ray you have to be attention of it, and that piece of bone here, that the lesser tuberosity fractures. And just for your knowledge, you never get isolated lesser tuberosity fracture. This never gonna happen. So the patient, that means he get a posterior dislocation, even if the shoulder in, that means he get a posterior dislocation and he relocate it again. But you never get isolated lesser tuberosity fractures. So if they just notice this piece of bone here, they know this guy is outside. So unfortunately, this guy, he was like that. They admit him because of the first time epilepsy. They keep investigating him. He stayed in the hospital for a couple of weeks, complain of the shoulder pain. My shoulder is painful. I have a few pain, and okay, get a CT scan, and that his CT scan after maybe 3 weeks time. I was away at that times. Okay, they spoke with the consultant in the hospital. Okay, we'll try to see if we can do closed reduction. So imagine that three weeks, almost completely locked posterior dislocations. The guys, they tried to put it back and they completely broke it. So now he's almost 4 weeks. When I came back, he had this small capital fracture here. His GT is off, had locked posterior dislocation, and he's 68, which is very young, trust me, in this country, very young. So I came through option. I give him the option, we try to reduce it, put it back. His chance of AVN almost 150%. His chance of fixation to fail, very high, given that we have a very minimal subchondral bone around the humerus head. And he would need a definite surgery. So I gave him the option to go with a reverse shoulder replacements. So that's what we give it for him. So we get him a reverse shoulder replacement. You can see his pacemaker is almost like I felt it sometime in axilla. I wasn't even able to use a dicermy to clean the glenoid. He's doing very well. He's very happy. I discharged him. The key when you do this case is to repair your GT. So this GT wasn't there. This GT all fixed it with special sutures, and there's a special technique we can go through it as some mistake. The knee suture technique to put back the GT, because your outcome for trauma care, it all rely on the repair of your GT fractures. Before, people tend not to repair it, and the patient overcome, they get a good forward flexions and they're happy with that, but they never able to do external rotation while elevations, which is a crucial thing, because that's the most functioning thing for your shoulder. You needed that for your hair, for yourself, do anything, either forward flexion while you external rotate, an abduction while external rotate. So unless you have a GT, you'll not be able to do this movement. That's why it's quite crucial, and it make a big difference in terms of the outcome to get your GT back in place. So this lady here, that's I know this. The male. He's a 65-year guy. He the mechanic actually. He came with a stiff joint. You can see that he already get his proximal migration, his head almost articulated with his acromion, his MRI completely retracted cuff. So the main problem for him, not that, the main problem, he does have completely posterior erosion. I didn't get his CT scan to note it, but he had like almost what we call like Walsh type 2, B2 glenoid, whereas there is eccentric subluxation of the hip with completely posterior effusions of the glenoid. So he does have like a retroversion glenoid. So this is very difficult to manage it with the anatomical shoulder replacement. So even if he's 65, I explained to him and we go through it, and we went through a reverse shoulder replacement for him, try to get everything back on track given his fact. And he came back to me when he's 4 years. That's his video here. So I'm not sure if I'll be able to play it or not. So that him here, almost 4.5 months. He's one of the few patients I use the deltoid split approach for him. Imagine this guy had a reverse shoulder replacement. You never get that. The only thing usually limited with them, they don't get great internal rotation. Even if you try to repair back the subscap, even if you try not to release a lot of the pec, they don't get a full internal rotation. But apart from that, they're fine. This guy he didn't complete 6 months. You can see the scar is still fresh there. He's quite happy. Discharge him back. So I will end up with the one quote by Charles Neer. That's what he said. He said the shoulder arthroplasty gave a good pain relief and function with durable results, no doubt about this one. But the most important thing, in a faithful and capable hand. So we need to sort about it. We need to sort about what kind of shoulder placement we're going to do it. And we should be capable to do this procedure. After that, trust me, you're going to get an excellent outcome more than anything. Thank you very much, guys.
Thank you so much, Dr. Mohamed, for this very interesting talk. Dr. Ibrahim, if we have any questions to Professor Mohamed?
I have two questions to Mr. Gaafar. First one, what do you think about the technique invented by Prof. Bolio and Pascal Bolio in France, the bio-RSA, the bone increased offset reverse?
Sorry, Ibrahim, your line is break, but I think I heard few things about Pascal Polo bio.
Yeah, the bio-RSA.
I think his idea is nice. Actually, this patient, the last guy I did, the one I showed his video, I put a graph for him, and I used the equipment invented by Pascal, to harvest the humeral head and then try to put it as a graph to correct your shoulder, your deformity. Generally speaking, it worked very well for a reverse, but it had a poor outcome for the anatomical, because your anatomical most of the time is cemented, so it didn't work. But for reverse, it's excellent. It's absolutely excellent, and it can come a lot of the deformity, a lot of big deformity. You can build completely a full glenoid from this graft, as long as you have a good humeral head, So it's a good idea. I use it for a few patients, and that last patient, I put it for him to correct his glenoid.
Okay, so we have this option also, the bio-RSA. We have another question from Dr. He asked about there is any recommendations regarding closure during reverse arthroplasty. You have like preferred approach or closure method?
Yeah, I would say like the data for us, like most of it, first of all, we use a delta vector approach. Okay, we think the delta vector approach is better. Like this guy, fortunately, he's doing very well. He's one of the few patients I did deltoid split for him, and that because we are running just a study comparing some groups with the delta vector versus deltoid split. But generally speaking, we go all with deltoid. deltopectoral. Even for the fracture, for everything, we prefer to go to the deltopectoral. We are talking about interval rather than muscle splitting. Outcome always is going to be better, you know. So regarding the closures, nothing special. Like sometimes even I don't need to close the interval. I just put maybe few tack with a Vicryl 2 or something like that, subcutaneous suture, and then I put monocryl for the skin. You can put it fully close the skin. Particularly if you are using a deltopectoral approach, there is a very minimal bleeding here, very minimal. You are using interval here, very minimal bleeding. You don't need anything special. But you can use anything. You can use for the skin clips,
Okay.
you can use nylon, anything.
Assalamu alaikum, Dr. Mohammed.
So, okay.
I have some questions.
Dr. Karim, go ahead.
Yeah, sure.
Dr. Mohammed, I have some questions about cases you have showed us about regarding the case female patients over 90 years. Why you didn't go for reverse shoulder? Why in shoulder with big head?
Yeah, still you can go for reverse. You're 100% right. But the only thing, as I told you, you try to, this 93 years old lady, you try to get a quick job for her. So
It's about time.
Yeah, so it's all about time. You need a short, but even for the implant I put it, I tried to put a CTA implant because even if I did repair the cuff, it didn't. This procedure overall, it doesn't take literally more than 30 minutes. She's a 93, very tiny lady. Her weight is 42K exactly. So you need a quick job for her, just to get her out, give her reasonable functions and pain-free, and should be okay. You don't need even to spend the time to try to repair the cuff and doing anything for her. So the CTA in general for them, for someone low demand to some extent, they're fine in the quick procedure.
طب دكتور محمد يعني the same case is that prosthesis with a big head يعني it depends on function of deltoid only ولا برضه it needs functioning rotators يعني.
In general, you rely on the deltoid. The problem in the hemi, if you don't have intact rotator cuff, or if you you repair your GT fractures and you put it back in place, the problem with the hemi, if the GT didn't heal, they end up with the proximal migration. That's the main thing with them, because you lose the the superior suspend of your rotator cuff, so they end up with the proximal migrations, and that's why you get that large head. So that's what it calls CTA. So, and the idea behind it is to migrate. So when they migrate, they're going to articulate with the acromion, and they still be able to abduct. It's still, the function is limited. You're not talking about any kind of an abductions more than a 90-degree here. But for someone like her, I think she'll be okay with this, you know. Forward generally they do well, but the abduction usually reach about 90-100%, not more than that.
طيب سؤال تاني يا دكتور محمد بخصوص الكيس with seizures. First question, when you operate these patients يعني هل في duration معين after the last attack of seizures?
Sorry, Dr. Karim, are you talking about, the elective or trauma cases?
Patients with
the guy with the posterior dislocation with epilepsy. Yeah, so it is like emergency case. So the Dr. Karim asked about there is any precautions.
These patients is liable for relocations. These patients are liable for relocations.
Yeah,
you can replace and then he will dislocate again.
Yeah, so for me, like if you have a dislocation, you need to fix it as soon as possible. You try to get it as soon as possible. Particularly if the patient young, you want to give him the best chance, you know. But those guys, first of all, particularly when you do the CT scan, always look for how much amount of subchondral bone do you have, because that's where your screw will gonna hold. Like even if you are able to reduce this patient and you put it and you fix it, sometimes they don't hold because you have a very minimal subchondral bone remaining there. Bear in mind, this guy, they have a very high chance of AVN. So if you put a very long screw and they end up with the AVN, you end up with implant that protruding your humeral head, and you end up with the problem from only humerus to the glenoid now. So But still, I will try to fix it, particularly if I will try to get him to theater as soon as possible. I'll try to fix it, but I always have the shoulder replacement in the set. I always consult the patients before the surgery. If I feel at any stage I'm not able to give you a stable fixation to allow you to move immediately, I'm going to replace that. Because as I told you, the outcome of the shoulder is not relying on how nice looking x-ray you have. It's really about how good function is it. So if I put this patient, I fix him, I put him in the sling 6 weeks, definitely I will get reasonable x-ray, but poor function. They don't accept it. I don't accept it. So for me, I better put him a replacement, get him early moving, good functions, and try to put it in the way to reduce his complication. Bear in mind that I may need a surgery in the future, so try to avoid any kind of a lot of cement, anything that could make his revision in future difficult.
I'd like to ask you something about the short stem design. The short stem design relying on the metaphyseal bone stock. So I think it's not matching for all your patients, or this is for specific patients, you know.
Yeah. So generally speaking, if I show you that last guy. So this last guy here, I didn't put any cement for him. His fixations completely rely on metaphyseal, and that's why people moving. So this stem literally sitting here doing nothing. And actually sometimes make your surgery difficult because you have a lot of variations in the neck shaft angle. Now the implant now is 135, that's when I use it, but that's not the standard for one patient to other. Sometimes if you have like deformity of the mid humors, it make it difficult. So again, most of your stem rely on metaphyseal, and regardless how's the patient poor bone quality, the metaphyseal generally they will occupy for post-coated implant. So they do well in general if you put it well.
I'm talking about I'm talking about the short stem design. There is you showed us there is few new short stem designs. I think this is shorter than 135.
Yeah, you're talking about this one, is it on the right?
No, go back to the
are you
stems.
You're talking about
no, the next slide. Go
this?
back. Yeah, this one on the right side.
Right. Yeah, so that's me. Yeah, so that mainly relies
on the right. The Boris coated one.
Yeah, so the Boris coated may rely on metaphyseal fixation. So in general, you should get in the 90% of the cases, you should get stable enough bone quality to fix that. Sometimes this kind of implant, they have a different size of the cup itself. So they have a different size, and you can increase it in the way to make it like a breastfeed over the metaphyseal.
So it looks like the augment or something, like
exactly,
if you have like some defect or something.
Exactly. And you can, and even if you find yourself like the metaphyseal of the patient had not enough bone, you can take bone graft from the humeral head. You have a big source of a humeral head, and you harvest it from there, put it completely over your humeral side, and then bang it. It's the same like acetabulum. What you do it for the acetabulum?
Yeah. You know, I'm working downstairs in the hips.
yeah. So more or less of that always. So this implant is still it's really is new. We don't it's not being used in it's not approved yet in Europe, but they start use it in US now.
Okay. So Ms. Prof. Ashab, if you have any, there is no question now.
سؤال اخير يا دكتور محمد بعد اذن حضرتك. دكتور محمد, young patients with juvenile rheumatoid arthritis, we saw such cases 30 or 40 with juvenile rheumatoid arthritis. They have arthritic shoulder with eroded glenoid and non-functioning rotators. يعني how to approach these cases especially with this young age. يعني if we go for a reversed shoulder, what about longevity? يعني?
Yeah. So see, like, I think the best one talk about this is Pascal Polo. He had like a big series of the case with inflammatory arthroplasty in general in the young patients. And in his series, he find the only solution for that is the reverse shoulder replacement. Like he tried everything with those patients. He tried to put a hemi for them. He tried to do reconstruction of the tendons, and he used a latissimus dorsi transfer. Sometimes he used trapezius transfers. It didn't work for him. He even reached a point that sometimes he thought it may be the problem in the quality of the tissue. So he put an allograft and it didn't work. So he find the only outcome for this patient. They all failed. They didn't do well. The only solution is the reverse shoulder replacement. Unfortunately, it's a sad story for young patient to do that. But I think that's the only option for them, at least at this stage. And I think with these short stems, the revision is much easier because you don't lose a lot of bone, you know? So and most of the patient, they would like to go, like, even if we explain for him, you are too young to get for this operation, most likely within 20 years in the maximum, you need another surgery, they're still happy to go for it. You tell you know, listen, that's the time I want to enjoy my life. I don't want my shoulder when I'm 60, I need it now. So unfortunately, so far, that's the only data we have it here.
Just last question, Mr. Gaafar, regarding the conversion from arthrodesis to arthro.
Yeah.
What the preference? I have no idea about the shoulder.
To be honest, I didn't have, me personally, I didn't have any experience with those cases, actually. I did the other way. I did arthroplasty that failed with the location. I put arthrodesis for them.
Arthrodesis.
But I didn't have an experience here. I don't know one particular island does that. I know Basim in Harvard, he used to do a few of them, but in Gary, you're talking about reverse here for them, most of the cases. But me personally, I don't have experience on that, to be honest with you.
Thanks so much. Finally, I would like to thank from the bottom of my heart Professor Mohamed Gaafar from St. James Hospital, Ireland, my dear brother Dr. Ibrahim Said Kamar from Sligo University Hospital, Ireland, and Dr. Karim. Karim, ابنك اللي كان
يا دكتور محمد
بيضحك عليك ده لو ما جبتوش في المناقشه انا مش هدخلك تناقش يا كريم. ماشي؟
حقيقه يا باشا.
لازم تجيبه معاك في المناقشه يا كريم.
حاضر.
Thank you so much.
Thank you very much, guys.
شكرا.
Thank you so much. وان شاء الله نراكم الجمعه الجايه مع احد الاميننت ستارز برضو في الكونتينيويشن اوف اور كورس. Thank you so much. وطبعا يعني تشريفكم على راسنا. شكرا دكتور ابراهيم. شكرا دكتور محمد بيه.
شكرا.
السلام عليكم.
شكرا جزيلا.
الف سلامه. عليكم السلام.